Good afternoon, everybody, and thank you very much for joining us on the fourth and last webinar of the Sports Medicine webinar series hosted by the New England Baptist Hospital. We're very happy that you're with us today. The agenda that we're going to be following, we're going to have a 20-minute presentation by Dr. Kimball and also a Q&A of around 5 to 10 minutes. So feel free to send your questions via the chat feature that you will find on the right-hand side corner of the control panel of the webinar software. We will be collecting those questions throughout the talk, and we'll answer as many as possible in the time that we have at the end of the session. For those of you who are not familiar with the New England Baptist Hospital, we are a specialty hospital. We are the only hospital in the New England area that specializes exclusively in orthopedic care. We actually have the largest volume of orthopedic cases in the state of Massachusetts. And it's that specialization and the high volume of cases that give us a unique level of expertise in orthopedics, and that's what we want to share with you through this webinar series. We hope that you come away with good information on injury prevention if they're related with sports, and some also good knowledge on treatment options if you already have an injury. The topic for today is how staying in the game after a hand, wrist, or elbow injury, and we're very lucky and very happy to have with us today Dr. Hervey Kimball. Dr. Kimball is an orthopedic surgeon at the New England Baptist Hospital, and he also holds an academic appointment as a clinical instructor of orthopedic surgery at Tufts University School of Medicine. He earned his medical degree from Georgetown University School of Medicine in DC, and he completed a residency in orthopedic surgery at the University of Connecticut Health Center. In addition to that, Dr. Kimball has a fellowship in hand and microvascular surgery from Duke University Medical Center. He also completed additional training in elbow surgery at the University of Western Ontario, the Mayo Clinic, and the Hospital for Special Surgery in New York. Dr. Kimball specializes in hand, wrist, forearm, and elbow problems, and some shoulder problems. So without further delay, he is Dr. Hervey Kimball.
Good afternoon. Thank you for joining us for this webinar series. Today we're going to look at upper extremity injuries, prevention, and treatments for these type of disorders. As many of you may recognize, this is Rajon Rondo, star of the Boston Celtics, and this image here shows an injury he sustained a couple of seasons ago where he dislocated his elbow. It's really a testament to him and the physicians and training staff that he was able to get back to play very quickly after a couple of missing just a couple of games. So that's what we'll sort of look at and touch on with this discussion today. How can we help keep you in the game? So we'll talk briefly about prevention and look at some relevant anatomy. We'll also look at the common problems that we see in the office in treating patients and athletes. When we consider specific musculoskeletal problems, we often have to evaluate the type of injury that the athlete or person has sustained. We also take into account their prior level of activity, and also expectations are very important in trying to understand the person's need for return to work or sport. It's very important for us as physicians to also evaluate and weigh psychological impacts of injuries for patients. We do know that training and conditioning improves balance, posture, coordination, and endurance. These are all very important things for helping prevent injuries. Also, when we look at how trainers guide patients and athletes, technique is very important. We try to avoid techniques that would cause excess stress on tendons and ligaments. Injury prevention also involves us evaluating risk factors. There may be specific anatomic problems or issues for younger athletes, and if we address these or guide training around them, we can help prevent injuries. An example might be the younger baseball pitchers. Well, we do know that excessive prolonged pitching can lead to injuries to the ligaments of the elbow. Also, it's important for these young athletes to have an appropriate recovery time. We don't really want them pitching every day. And then specific pitches might be detrimental, like curveballs. We try to have our younger pitchers avoid those to prevent specific injuries. Patients often ask me about supplements. Are these helpful? Well, the data on this is not quite so clear. It used to be a year ago that I would tell patients glucosamine and chondroitin sulfate, both readily available supplements to help with joint pains, were shown to be better than placebo. Unfortunately, new data would suggest that there may not be much of a difference. These other medications that are supplements listed here also have not been proved to provide a means to healthier joints or preventing injuries. Physical therapy is very important for us as physicians in helping rehabilitate and recover patients. We do look to individualize the program so that we're directing the specific therapy for the injury or the surgery type that's been performed for each patient. In Europe, there's been a real push or progress towards early sport motion in the sense for recovery and return to sports. If our athletes are using the same motions very quickly after surgery or injury, we find that they're able to recover quicker and get back to sport or work. It does take a lot of hard work, this recovery, and we're here to help our patients get through that. We'll take a few slides to look at the anatomy of the arm. As some of you may know, there's three major nerves that course through the arm: the median nerve, the ulnar nerve, and the radial nerve. Each one of these nerves have specific problems that can be associated with them. Beyond simply just having a direct injury to the nerve, there's areas of compression that can occur, and we'll talk a little bit about that later on. When we look at the bone anatomy of the upper extremity, there's the humerus bone, your upper arm bone. There's two bones in the forearm, the radius and the ulna. And then there are 27 bones in the wrist and hand. Along with the structural bony anatomy, we then have a layer of muscles that help move our joints. Multiple muscles in the arm and forearm are important in moving your elbow, but then also the ones in your forearms help to move your wrist and hand. Fortunately, in the office, I don't see too many patients with elbow macaroni syndrome, but I do see lots of patients with tennis elbow. What is tennis elbow? Well, we describe it as epicondylitis. It's a very common problem that essentially is pain at the outside part or the lateral part of your elbow. Specifically, when we look at specimens, it really involves micro tears within the tendon itself, and we refer to that as a tendinopathy. It's a very, very common problem in ages for patients 30 to 65. In looking at prevention for this particular problem, we have found that stretching and strengthening exercises can be very helpful in alleviating the symptoms and then also preventing recurrence. Some of you may have seen patients or have had to try braces like these. This is a tennis elbow brace, and it's a strap that holds the muscle and helps dissipate the force that might be pulling on the area where the tendon attaches to the bone. We call that a counterforce strap. It seems to be helpful in about 50% of cases. When looking at other potential treatments for tennis elbow, cortisone is a common injection that's used to help alleviate the symptoms of long-standing tennis elbow, maybe symptoms beyond a couple of months. There have been some other potential injections that have been sort of proved to be helpful at times. Those might be an autologous blood injection or possibly even platelet-rich plasma. We may discuss that a little bit later. For patients that have had symptoms over a year, well, surgery may be an option for them. There's several different procedures that can be done, from the original described open operation to an elbow arthroscopy procedure, which is done in the operating room with small cameras and small instruments about the size of a pencil. Or in the office, a percutaneous release could be performed. Here at New England Baptist Hospital, we've been doing this procedure over 10 or 12 years and have had at least 60 patients enrolled for this. We found that this particular operation tends to provide equal results to the open or arthroscopic procedures, with the benefit of a minimal incision, faster rehabilitation, and minimal scarring. There's also the thought of cost savings for this. Moving on to other muscle injuries that can happen around the elbow. Well, biceps tendon rupture is a fairly common problem. It often happens in middle-aged men, and it's typically a lifting type of an injury. The tendon will pull away from the bone as depicted here, and with that, the tendon will and muscle will retract into the forearm. So it'll look like the muscle is a little bit bigger or deformed for these patients that have this injury. Why does this happen? Well, we feel that the rupture of the tendon is related to degeneration of the tendon. And I oftentimes will tell patients it's like imagining the tendon being a rope, and the inside of the rope has some frayed fibers. The outside, it looks like a standard rope, but inside the fibers are frayed, and that weakens the tendon or the rope. And with force, it can cause the tendon to pull away from the bone. We've done well to address this particular problem for younger active patients with surgery, and we've found that with newer techniques we're able to very effectively repair the tendon to bone with very good strength, and that provides for accelerated rehab. It used to be that patients would be put in a cast for 6 weeks, but now right after surgery we're able to let them just start moving day number 1. They usually achieve their full motion by about 2 to 4 weeks after the surgery, and they can start strengthening at 6 weeks. It's a real advantage for our patients. Moving on down the arm, skier's thumb is a common problem here in the Northeast. What is skier's thumb? It's a tear of the collateral ligament of the thumb on the inside part of the thumb, shown here on this picture. Most patients that have this type of an injury don't need surgery, but instead need a cast or a splint for about 4 weeks. Therapy can be helpful afterwards to help regain the motion and strength. However, if the joint is unstable, that is more than likely going to be an indication for surgery. The slide picture on the bottom right shows a tendon that goes over the area of the joint where the ligament gets detached. And in some instances, the ligament can flip to the other side of the tendon, and in these instances, the ligament can never repair itself down to the bone. That's called a Stenner's lesion, and that's always an indication for surgery. This slide here depicts, in a cartoon fashion, how ligaments could be repaired for the thumb. It can either be done through drill holes in the bone or an anchor that's placed in the bone with suture that allows us to tie the ligament back down to where it originally was inserting. With these types of surgery, we're restoring the stability to the thumb joint. Rehab is similar to as if it would be had you not needed surgery. Again, a cast or a splint for about 4 weeks, and then return to strengthening and therapy with being able to return to skiing or sports at about 2 to 3 months. Another common problem that we see in the office is injury to the triangular fibrocartilage complex. It's otherwise known as the TFCC, and this is on the ulnar side of your wrist and is a cartilage and ligament support structure. You can get a sense of that from the picture here. This can be commonly injured after a fall, and for such falls, at times you may break a bone, but in this case, this is an injury to a cartilage. And with these falls, you can get tears of the cartilage complex. In older patients or athletes, we may see degeneration of the cartilage itself, not from one specific injury, but over time. And we've also seen patients with an anatomic variation where one bone is a little longer than the other, and that causes the impaction of the carpal bones or wrist bones to the forearm bones. And by having this variation, the cartilage wears away over time. So for those acute injuries where a fall causes a tear, oftentimes we cast those patients and they can improve. We know that for the triangular fibrocartilage complex, a portion of it helps stabilize the two bones in the forearm. So it's paramount that these patients that are casted do not have or don't have instability. For those that are unstable or that casting doesn't help, we think about doing surgery for these patients. And this video clip that we'll show here will help get a sense of what this arthroscopic procedure would look like. That blue line in the center of the video is a suture that's placed arthroscopically, and as it's pulled, it becomes taut, and we're able to perform that type of a repair through very minimal incisions. For rehabilitation with TFCC injuries, oftentimes we'll cast the patients after surgery for about 4-week time or 4-week period, and then afterwards we have them begin therapy for strengthening and range of motion. We expect oftentimes patients will be able to return to their sports or prior activity levels at about 3 months. Finally, we'll talk a little bit about carpal tunnel syndrome, a very common problem. It refers to median nerve compression at the level of the wrist. The nerve travels under the transverse carpal ligament through a tunnel, and with compression of this nerve, patients or athletes will experience numbness in the median nerve distribution, which involves the thumb, index, middle, and ring finger somewhat, and oftentimes pain. When we see patients with this particular problem, we're oftentimes confirming this diagnosis with nerve testing. This slide here depicts a little bit more readily the anatomy and understanding of how this really is a tunnel. On the back of the wrist are the bones, and on the palm surface would be the ligament, and within this tunnel travel the nerve and the tendons that help bend your finger. With aging or with injury and trauma in this particular area, the space or that tunnel becomes a little tighter, and with that you can get compression of the nerve. For mild cases, we've found that splinting and injections can be very helpful for patients. We don't know that anything really can prevent carpal tunnel syndrome, but if you do have mild symptoms, these non-operative treatments can be very effective. Unfortunately, there are some other recommended treatments out there that have not been proved to be beneficial by true studies. Those would include cold laser, ultrasound, or hand therapy. When we talk about the more significant cases of carpal tunnel syndrome, a nerve testing might show that they have moderate or a severe nerve compression based on neural parameters. We usually suggest surgery for this, and that is in the form of releasing the ligament to take pressure off of the nerve. And this cartoon shows a little bit of what that would be like. Now, ultimately, the ligament reconstitutes with scar tissue, recreating its function, but with less pressure on the nerve. We've found also that with minimally invasive techniques, we can perform this operation. That's called endoscopic carpal tunnel release. Over the initial course of recovery, patients have less pain and are able to return to work and sports a little bit earlier than with the standard open operation. So as we see patients and athletes aging, we find that there are lots of important things that we as physicians need to do to try to help keep them active and stay in the game. This slide here shows some of the athletes that participated in the 2009 World Masters Games in Sydney. If you look on your right, you'll see a gentleman who came in third and won a bronze medal for hurdles. And you may not know this, but his age, he's 85 years old. The next game is games are in New Zealand in 2015. So we will be able to take some questions, and hopefully I'll provide some more answers to those of you out there that have had to deal with these particular problems or have some upcoming issues.
Great. That was an excellent talk, Dr. Kimball. Thank you very much. We do have a few questions that I would like you to answer for us. The first one is around the PRP, the plasma injections. Do they work well for elbow injuries? Should a person try them before trying surgery, and what are the risks associated with it?
Well, that's a very good question. As I see a lot of patients with tennis elbow, that's a common question. Unfortunately, I don't have a really set answer for that. Industry-funded research would suggest that it is beneficial for patients that have tennis elbow problems. However, some other clinical studies have shown varying results. At this point, several insurance companies will cover that type of an injection prior to surgery, but some of them won't cover it, and the out-of-pocket cost for patients might be pretty significant. We do know that patients that have tennis elbow, that it's commonly a self-limiting process. That is, that over time it will get better on its own. So we try not to push any specific treatment for them, but some do elect to have that type of a treatment. I think the real advantage for that type of an injection, platelet-rich plasma, is the growth factors that are contained within the injection. It would make more sense to me to have that type of an injection given for an acute injury where a ligament has been torn from, for example, the knee, and this will add in some of the healing factors that are necessary for early healing. For problems like tennis elbow, this is more of a degeneration of the tendon, and there's not a lot of inflammation that's seen on histologic or specimens that are retrieved. So we don't really understand how it would necessarily work, and the studies would suggest that there's no clear evidence that it is working.
Okay, great. Thank you very much. The next question is around carpal tunnel surgery. What are the chances that the surgery will be successful, meaning no pain or numbness after the surgery?
That's another great question, something I get asked very regularly. Carpal tunnel syndrome, when it's diagnosed properly, the treatment for it with surgical release is a cure for the problem. We find that patients have excellent results in the 90 to 95% range. But again, some patients will come in to see us or with symptoms that don't really fit specifically carpal tunnel. And in those instances, we may not be quite as successful in solving their problem when we do carpal tunnel release surgery.
Okay, so accurate diagnosis is very important.
Correct.
Okay. And our last question for today, could you describe a golfer's elbow and how it compares to the tennis elbow that you mentioned earlier, and are treatments the same for both?
Sure, that's another great question. Golfer's elbow is medial epicondylitis, tennis elbow is lateral epicondylitis. So in essence, it's the same process, just on the inner part of your elbow for golfer's elbow. and the outer part for tennis elbow. Again, we think there's a problem with the tendon, an aging process that's occurring, and with this aging process, there are microscopic tears within the tendon. Tennis elbow is much more common than golfer's elbow, but essentially the same process, and the treatments for them are the same. So oftentimes, if patients are able to perform stretching and use a strap, that may alleviate their symptoms most of the time. And then if it's more significant or over a period of months, they might opt for an injection. And then later on down the road, very few patients really need it, but might consider surgery.
Okay, that's a great answer. Well, those are the questions that we had for today. We want to thank again Dr. Kimball for an excellent talk, great information that we hope was helpful for everybody who joined us today.